Okay, so I will pause the recording. Now we are going to start with part 3 of this lecture, and this is not going to take a very long time. So I'll first share the screen. All right. So I hope the screen is visible. Can somebody confirm if he or she is there?
Yeah, clear, Doctor.
All right, thank you very much. So part 3 is about the surgical options. It's not our field. So we'll go very quickly through this. I've included this because you should at least have some knowledge of what is happening currently in this arena. We have a standard technique for doing the operation, which I mentioned is transurethral resection of the prostate. It is known as TURP. But there are many new minimally invasive techniques or procedures that have been developed, and they are continuously being refined, and they have been adopted by many urologists, particularly in Australia and South Africa, and perhaps in other countries as well. All right, so we will very quickly go through this section. So the first is transurethral resection of the prostate, which is considered to be the criterion standard for relieving bladder outlet obstruction secondary to BPH. All right, so it is still the gold standard. In other words, indications for this is acute urinary retention, failed voiding trials, which again means urinary retention or improvement in the post-residual volume, recurrent gross hematuria, urinary tract infections, renal insufficiency secondary to obstruction, and failure of medical therapy. After this, we try this option, okay? So TURP is performed with regional or general anesthesia or spinal anesthesia, and involves the placement of a working sheath in the urethra through which a handheld device with an attached wire loop is placed. Then high energy electrical cutting current is run through the loop so that the loop can be used to shave away the prostatic tissue. And when I show you the images, you will understand what I mean by this. The entire device is usually attached to a video camera to provide vision for the surgeon. Okay, so this is how we do it. We have this device. Firstly, it is done under general or regional anesthesia. Then we have this high energy electrical cutting device, which is this one. It is known as a resectoscope. So you pass it through the urethra and you reach the prostate, and it has a wire loop at the end. So this is a blown up view of the wire loop, and with the help of this, you shave off the tissue. You see, high energy electrical cutting current is run through the loop so that the loop can be used to shave away the prostatic tissue. So you see the tissue that has been shaved away on this side. This side, it has yet to be done. So this is what TURP is. You get pieces or shaved away portions of the prostate from during this surgery, okay? And then you can send them to the pathologist for further evaluation if there is any suspicion of cancer or to rule out cancer, okay? Right, so the complications, there are some complications, obviously. When prostatic tissue is cut away, significant bleeding may occur, possibly resulting in termination of procedure, blood transfusion, and a prolonged hospital stay. But it all depends upon the expertise of the surgeon, right? A urinary catheter must be left in place until the bleeding has mostly cleared. But if the surgeon is experienced, then it doesn't cause these complications, and you do not need a long hospital stay. Patients are usually monitored overnight and discharged the following morning with or without a urinary catheter. This is another problem. Irrigating fluid may also be absorbed in significant quantities through veins that may cause dilutional hyponatremia. And this is termed transurethral resection syndrome, right? So hyponatremia, and that will have its own consequences. Another problem with this operation is that the large working sheath combined with the use of electrical energy may result in stricture of the urethra. The cutting of the prostate may also result in partial resection of the urinary sphincteric mechanism, causing the muscle along the bladder outlet to become weak. Okay, so four complications: bleeding and dilutional hyponatremia, stricture formation, and resection of the urinary sphincteric mechanism. As a result, the ejaculate goes backwards into the bladder, which is known as retrograde ejaculation. Urinary incontinence may result, and high energy current or heat it generates may damage the nerves, which are close to the prostate. And that's a branch of the pudendal nerve. I'll show you in the next figure. Okay, so TURP is the gold standard. It is also known as the criterion standard, as we refer to it. It causes significant bleeding. It causes dilutional hyponatremia. It could lead to structures, loss of sphincteric control, and retrograde ejaculation, incontinence, impotence, right? So this is the prostate gland over here, and you see that this branch of the pudendal nerve, or the pudendal nerve itself, is passing close by, and if you give heat, this nerve could be damaged, and that could lead to sexual dysfunction. All right. Now we go on to minimally invasive treatments. Minimally invasive therapies are designed to decrease the size of the prostate gland while avoiding the adverse effects of transurethral resection of the prostate. Most minimally invasive therapies rely on heat to destroy the prostatic tissue. The heat is delivered in a limited and controlled fashion, and they also allow for use of milder forms of anesthesia, which translates into less anesthetic risk for the patients. These techniques are constantly being refined. They might not be as effective as TURP, okay? But many urologists have stopped using TURPs, and they have taken up one of these techniques. Transurethral incision of the prostate, in which you just make two grooves through the urethra. It has been used for many years. It may be performed under local anesthesia or sedation. This TUIP is suitable for patients with small prostates and for prostates unlikely, or for patients unlikely to tolerate TURP, okay? It has been associated with lower incidence of bleeding, fluid absorption, which is dilutional hyponatremia, retrograde ejaculation, impotence. So we have a condition attached to it, which is small prostate glands, and it has got less adverse effects than TURP. Now, lasers are very commonly being used, and there are different procedures and different techniques of using lasers. They deliver heat to the prostate in various ways, causing tissue death by coagulative necrosis with subsequent tissue contraction. Laser coagulation of the prostate in this specific sense has met with limited results. So that is one drawback. It's not as effective. The approach is similar to TURP because it is a transurethral approach, and the surgeon performs under general or spinal anesthesia. The prostate is either resected, which is known as enucleation, and ablated, which means destroyed. Patients require 1 to 2 days of hospitalization while the bladder is irrigated with a catheter. There are several types of laser used to perform this procedure, and they are green light laser, holmium laser, and thulium laser. Okay, so holmium laser, they are the most commonly used ones, and they are perhaps the most preferred ones. Lasers may be used in a knife-like fashion to directly cut away prostate tissue, and this is known as holmium laser enucleation of the prostate. It allows for simultaneous cutting and coagulation. It is safe and effective regardless of the prostate size. And this is a simulator on which the doctor is practicing holmium laser. You know, he has a screen and he can see what he's doing. And he is, with the help of this laser, he's ablating the prostatic tissue, right? And this is the apparatus for generating the laser. So this transurethral restriction syndrome is not seen with this technique because you do not need a lot of irrigation, okay? Or when you use it, it is isoosmotic saline that is used for irrigation of the bladder. Additionally, removed prostatic tissue is available for holistic evaluation, whereas other techniques like vaporization ablation techniques does not provide tissue for evaluation. It may prove to be the new criterion standard in the surgical intervention for prostate gland, okay? And there is also a thulium enucleation, which is almost the same, or you can call it a variation of holmium laser. So this is green light laser. You know, this is how you remove the tissue. On this side, the prostate gland tissue has been removed, and it is being removed on this side as well, okay? This is the apparatus that produces the green light laser. And, you know, green light laser, there's certain way we'll not go into the technicalities. So it is just there for your reference. If you want to go into more details, you can read it. But laser enucleation and blunt gentle mechanical dissection is used. And this is known as en-bloc enucleation technique, and it provides a better visualization of the capsule. So this is how you are enucleating, you know, on this side, you're removing it. So that is why how you have detached it. And then you will in some way get it out of the body through the urethra. Then we have a microwave therapy. It uses microwave energy that delivers heat. It is the surface closest to the probe is cooled to prevent injury. Heat causes cell death and tissue contraction, involution of the tissue. This can be performed in outpatient with local anesthesia. So TUMT, transurethral microwave therapy, is associated with significant prostatic swelling, and it requires placement of urinary catheter until the swelling subsides, okay? So it has a place somewhere between medical therapy and transurethral resection, which is the criterion standard so far. So with this technique, surgical retreatment rates are higher than with TURP. That's a drawback, and this is how the heat is delivered to the prostatic tissue, and surrounding tissue has to be cooled down, and the prostatic cells will die and they will involute through apoptosis. Right, then we have a needle ablation as well. Okay, you provide heat with the help of the needle, and this is not a very popular technique though, but maybe still under development. This is the same one. High frequency radio wave are used to produce heat, and it has a device with needles. It is performed under local anesthesia, and similar to microwave, radio frequent treatment is quite popular, and a number of urologists have experience with its use. It provides significant relief of symptoms and better urine flow, not quite to the extent achieved by TURP. All right, so the bottom line is that all these new procedures are under development, and they are slowly and gradually being adopted by the urologist, and how successful they are, we will get to know about them when the clinical trials become available. Then we have high intensity ultrasound therapy. The use is relatively limited. It is considered investigational at this time, okay? Again, it provides heat to prostatic tissue. The heat may be, or the ultrasound waves may be delivered rectally or extracorporeally, but remember, it is an investigational procedure, okay? And this is how it is done, through the rectum. This is a small little tumor that is being ablated with the help of this technique, but not yet in practice. Radio frequency generated water thermotherapy. It is known as reason. This is also used quite frequently. Okay. It is performed under general or spinal anesthesia. It uses sterile water vapor steam that is injected into the enlarged prostate of enlarged portions of the prostate. It causes the prostate cells to die, then leads to shrinking of the prostate gland. And this is what the apparatus looks like. It uses radio frequency generated water vapors. So whatever this technique is, sexual function is not affected by this technique, and complications include urinary retention as well as UTI. And this is the result of reason. You know, this is the compressed urethra and bladder neck or bladder outlet obstruction. Over here you can see, and after treatment you see that the urethra has opened up quite a bit, and the obstructive symptoms are most probably relieved. Okay. Then we have mechanical approaches are used, yes, less commonly, and are usually reserved for patients who cannot have a formal surgical procedure. They do not involve the use of energy. Prostatic stents is one of them. They have got certain complications like encrustation, pain, incontinence, and overgrowth of tissue. So this is a stent. It might remind you of the stent that is placed in coronary arteries in angioplasties, but the problem is that the tissue can go through these holes into the urethra. All right. So again, less commonly used. Urolift is another technique in which you mechanically try to open up the urethra. I'll show you the pictures. We're not going into details. This is not our field. So here is the equipment that is used for placing these mechanical sort of whatever you call it Urolift. Okay. So this is the device that is used over here. Implants, yes, we call them the implants. Okay. So the implants are fixed into place, and that is all. They mechanically open up the urethra. Okay. So this is a blown up view of the same picture. And then embolization, selective prostatic artery embolization to control bleeding secondary to BPH. This PAE, prostatic artery embolization, has yet to be established. Okay, this is you go through the femoral artery and then go back into the prostatic arteries, and you inject some material that will cause embolization over here, and it will destroy the prostatic tissue. And this is after treatment, and this is before treatment. All right. Right, then intraprostatic ethanol or botulinum toxin. Again, these are investigational treatments, and we will not go into details of these treatments. All right. And the last is this robotic, or the second last is the robotic assisted simple prostatectomy. And this is used for men with very large prostate, larger than 80 ml in volume. It is superior to minimally invasive approaches that I've shown you previously. And this is known as RASP, Robot Assisted Simple Prostatectomy, and it uses a Da Vinci apparatus or machine. The central part of the prostate is removed, and you see we have got different different instruments that have been placed inside the peritoneal cavity, right, or inside the pelvis. And the surgery is done through a robot. So here is the patient, and here is the doctor, and he will be manipulating these instruments through this robot over here. He has got many controls in his hand and in his feet as well. So here he's doing surgery. The patient is over there, and this is a close-up view of the robot, and he's performing surgeries. You can see that is something he's controlling with his feet as well. Okay. And this is the last slide for today. This is open prostatectomy, which means you cut the abdomen and then you an incision is made in the abdomen. The surgeon uses his finger to enucleate the prostate. So this is the prostate. He's with the help of his finger, he has removed the prostate gland. Patient is catheterized and catheter remains in place for many days. All right. So that is all for today's lecture. And if you have any questions, you can ask me now. Otherwise, we will stop for this week. So I guess there are no questions. So we'll stop here and I will see you next week. All right. Thank you very much for attending this lecture.